Thank you, everyone, and I want to thank you for inviting me here. Unfortunately, you're going to have to listen to me speak in English because the only other language I know is a little bit of Danish, and I don't think that would be very useful here. So today I've been asked to talk on the global threat from some emerging infectious diseases. And so I'm just going to give you some high points on these diseases, but then if there's any questions, we can go into more detail. So the big question, I think, is, with emerging diseases, are these really going to be global threats, or is this just some hysteria? To balance whether this is going to be an issue or not. And it really, I don't know if any of you had the pleasure a couple nights ago, I couldn't sleep, so I was fortunate to see what's called the blood moon, which was the event where we had a solar eclipse and then the sun was casting the moon so it became red. And as I watched this was the view from my backyard. I took this picture and it really struck me how incredibly different the moon looked. And if this had been a couple hundred years ago, I think the question would have been, is the world ending? What's going on? Oh my gosh, what's happening? And I think this really made me think about, with these diseases, is this the same thing? When we see this new disease, what does it really mean? So today I want to talk about a few diseases. Of course, the disease we've really been hearing the most about was Ebola virus disease. But we've also had big outbreaks of Middle Eastern Respiratory Syndrome coronavirus, or MERS, as well as the resurgence of some zoonotic influenza viruses, particularly avian influenza virus and some occasional swine viruses. So as you're aware, if you've seen any news, I'm sure, of this big public health crisis that occurred in West Africa due to Ebola virus. Now, we're calling this an emerging disease, but Ebola has really been around since we first learned about it in 1967 in the Democratic Republic of Congo. We've had multiple outbreaks, almost 30 outbreaks recorded since that time, but these have generally been small, discrete events with often 1 to a few cases to up to almost 500 cases at one time. We know Ebola is a virus that's, the host is in animals. We believe it's transmitted by fruit bats, but people are often exposed and pick it up initially from animals by contact with wild animals and hunting them, bush meat. They get exposed, it gets into people, and then the infection occurs by transmission from human to human to human within people. And in the past, we've had very good success through control of this disease, through implementing those classic measures for infection prevention control, through identifying cases, isolating them, quarantining contacts through contact tracing, strict infection control practices in hospitals, and then mobilizing the community for those practices, including safe burials, because burials where the tradition is to handle the body for washing or other customary practices is one of the seminal spreading events that we see with these outbreaks. So this year, this year we've been still dealing with a big outbreak that occurred in West Africa. And so if we look back to March of 2014, we first were notified of a few cases in Guinea. And then within a week, we heard about cases in Liberia. And within 2 months, we had cases in Sierra Leone. And so this was the first time where we had such a large event spreading so quickly over so many countries. And then it took off. And we had normally in previous outbreaks, because infection usually started by contact with wild animals, these outbreaks were usually in rural areas, more isolated, but in these infections, they got into urban centers. We had movement, we had spread across West Africa, and then in even to other parts, first of Africa with spread to Nigeria, and then on to a few other countries. So the infection took off, and by August 8th, WHO declared it a public health event of international concern. We had increased mobilization of international resources and a concerted effort through the fall and winter of 2014 to control the outbreak. And fortunately, through those efforts, we were able to start to bring what we call we started on the bumpy road to zero cases, knowing that as we're trying to control this, we'll have some improvement, some setbacks, some improvement to setbacks. And so if we look now, as of September 20th, we've had over 28,000 cases reported in West Africa, totally. The vast majority, again, of those are in West Africa. We had over 11,000 deaths in this outbreak. We've also had cases exported to other countries, to, I believe, 7 other countries. Some of those by air travel, a few of those by land. So this really did become a big international concern. And so if you look, this is a map of the situation as of this September, and it's a map of the 3 countries of West Africa, and the areas in blue are areas where they had cases reported. The darker the blue, the more cases were reported across Africa. So you notice that Sierra Leone here, when the darkest blue, had the significantly more cases, but almost all of the areas of the other countries were infected as well. So this really infected the entire area. If you look at the spots in orange, represent the cases that have occurred within the previous 7 days, and the cases in yellow within the previous 21. So what this is showing is that while most of the country has been infected, currently we are only talking about infection in a very few small parts. Within the last week, even after this graph, we've had only 4 cases total reported from West Africa. All of those were with one event over here in Guinea. And we haven't had any cases reported in the last week from Sierra Leone. So in Sierra Leone, we're only doing follow-up to monitor contacts and keep them quarantined to look for new cases. So the other thing that's very good news is all of these last 4 cases that were reported last week were from known contacts. These were cases that had been exposed to one young 10-year-old girl from the capital, Conakry, who had traveled to Furkaya to visit some traditional healers, and unfortunately she died. Those contacts were all identified, and these cases occurred within those contacts. So we, at this point, have no unknown chains of transmission going on. So we're very hopeful that we are wrapping this situation up and bringing it under control. One of the really highlights of this outbreak was the impact that it had on healthcare workers. Of those 28,000 cases, we had almost 900 healthcare workers infected in these 3 countries, and over 500 deaths. Over 50% of them had died. This is significant for 2 reasons. Not only because of the great impact just on healthcare workers, but it's very important to know that these 3 countries had some of the lowest rates of healthcare worker to population in the world. So they had very few healthcare workers to start with. And this has really devastated that community. So I mean, and this is unprecedented. We know that healthcare workers, unfortunately, are often kind of a sentinel for these diseases because of in this part of Africa, they can present looking like malaria or other common diseases, and so you may not institute any infection prevention control measures until the outbreak is known, and it's often then too late for those initial healthcare workers who were working on those cases. The other thing that we saw with this outbreak that really we haven't seen before is because of the number of international responders who came to help during the outbreak, we had a large number of medical evacuations and repatriations of people who had been exposed but needed to be quarantined, and they were going to be quarantined back in their home country. And so we had over 65 people who had to be repatriated in over 11 countries during this outbreak. In Europe alone, that was 13 people who had to be medically evacuated to 8 countries. So this was a challenge for the international community that they have to deal with. So what was unique about this? You know, the question is, as an emerging disease, is this because the virus is different and we need to worry about its spread, or is this about the response? And I think when we think of that question, we have to look at you know, what prompted this crisis. And I think it's important to remember that these 3 countries in West Africa had some of the weakest healthcare systems in the world. They'd come through years of civil unrest, economic crisis. There was culturally, there was a lack of trust in their government and in some of those issues that came up. So it made response there, identification of the issue and response delayed and difficult, and institution of some of the practices that we know really work to control Ebola difficult, and it took a while to understand the social context to make the community engaged in those practices. We also saw for the first time an outbreak where we had movements of large groups of people. We had an outbreak in urban centers instead of just rurally, and we had it spread across multiple countries at once. As I said, the systems were weak, so they didn't have the capacity to handle and cope with such a crisis, a public health crisis. And for this type of control, it took not just the medical community coming together and working to control it. You had medical issues, you had social issues, economic, logistics, and security challenges. I was in Sierra Leone for 2 months I guess it was early this year, in January, February, March, and it amazed me the amount of coordination that had to be involved. People were told in November that they had to go to their homes. They were prevented from traveling outside their cities. Businesses shut down. You couldn't open restaurants. You couldn't gather in more than 10 to 20 persons. You had curfews. You had to, if you were quarantined, some villages decided to quarantine the whole village, not just the house. So people had to be provided with food. They had to be provided with water because they couldn't go to their water source. What people helped them, other neighboring villages helped them with their crops, so because many of these are subsistence farmers. So people did that. It was a major event, and any country would have had trouble coping with it at that level. And the other really unique instance of this outbreak was that we had a need to develop and test new vaccines. And so they have been doing that. There are, I think, 15 potential vaccines, but 2 of them are currently being evaluated and used in phase 2, phase 3 clinical trials in Sierra Leone and Guinea for controlling this outbreak. And so where we are now, as I said, we've had less than 10 cases reported per week in these countries since July. Liberia has been declared free. since July as well. And, as I pointed out before, we just have had a few cases in Guinea. So we are hoping that with this outbreak, we're actually seeing those last few cases until we get to 0. So now I'd like to move off of Ebola and move on to MERS coronavirus. This is a novel coronavirus that was first identified in Saudi Arabia in 2012. Since that time, and under a lot of investigation, we've identified that camels, dromedary camels particularly, the one-hump camels, are likely a major reservoir, but the exact role that they play in transmission to people and how it's transmitted is not clear. While we think that there are sporadic cases that come from camels into people, we do know that the majority of human cases that get reported are attributed from human to human infection. And a lot of those numbers are driven by some outbreaks of nosocomial infections in hospitals, where we see sporadic cases, but then we've seen some outbreaks in hospitals. Fortunately, it seems to take close contact between people for these for human-to-human transmission to spread. If we look at the global situation, we see that since 2012, where we had a very few cases being reported, we've seen some years with large increases and some years where we had fewer cases. And these big, it's not showing up, the big years where we had large numbers of cases are years where we've had some large outbreaks in hospitals. And most notably in this year, we had, in red, you see the outbreak that occurred in the Republic of Korea, I'll talk about a little bit later, but that was attributed to, again, outbreaks in healthcare facilities. And so to date, we've had approximately 1,500 cases and about 40% death fatality rate in that. And if we want to look where MERS coronavirus is identified, the vast majority of cases occur on the Arab Peninsula, with 85% of the cases occurring in the Kingdom of Saudi Arabia. However, we have seen a number of sporadic cases in travelers who have returned from either travel or working in particularly Saudi Arabia, including cases into Europe. The majority of those cases that have been identified in other countries have been single cases that have not led on to other infections within those countries. So MERS cases tend to occur more in men than women. So the cases tend to be men. They tend to be older, and they tend to have underlying conditions and more severe disease. In primary cases that are identified. If we then see transmission on to secondary cases, those cases tend to be younger, healthier, and have fewer symptoms. So we see that the people who are spreading the disease tend to be the severely ill. As I said, the fatality rate runs around 40%, but we do see cases with mild disease and a number of asymptomatic infections have been picked up in contact, and those are in contacts of cases for testing with contact investigation. And overall, about, again, 20% of the cases have been healthcare workers. So again, we see an infection where healthcare workers are sometimes sentinels of the outbreaks. And that is actually how MERS coronavirus was identified, was a retrospective investigation of a hospital outbreak. So I pointed to those cases that occurred early this year in red, that occurred in the Republic of Korea. So in May of this year, a single traveler returned from the Middle East to the Republic of Korea, and by early July, Korea had 186 cases of MERS coronavirus. And most of these were limited to a number of health facilities. Intense investigation showed that there was no sustained transmission in communities. However, they did have one traveler from Korea who went to China while he was ill and became ill and got more severely ill there and identified. But that travel did not lead to any secondary transmission. So this is the epicurve for this outbreak, and you see this one person over here in May that onset early May, prompting this large outbreak over here. And this is important to look at. If you look at then they looked at these are the number of health facilities that became involved in that outbreak. And it's important that most of them, health facilities, had very few cases, but you had a number with a with a significant outbreak. And you wonder how this happened. Well, they had a investigation, and WHO had a mission that went there to assist the Ministry of Health, and they found out that there were a number of factors that contributed to this. First was that MERS coronavirus was not expected and unfamiliar to most physicians in Korea that were at these facilities, so that they did not anticipate and did not think to look for this disease. In Korea, at their healthcare facilities, they have very crowded emergency rooms, large numbers of people who actually spent days in the emergency room being treated and not being admitted to other wards. And they had multi-bed patient rooms with people being moved back and forth between different areas of the emergency room and out for testing. And they had suboptimal infection prevention and control measures. On the other side, the culture in Korea, there is a lot of doctor shopping, so that this person went to multiple facilities before he was identified. I can't remember off the top of my head, but it may have been as much as 6 facilities people would go to. So if they went one place and they didn't necessarily like the treatment or what they got, they'd go somewhere else to get a second or a third or a fourth opinion. And so that's why there's a number of places where there was only one person identified at that hospital, because people moved around to different hospitals. It's also a culture where when you're hospitalized, you have family members and friends who come and take care of you and stay with you the entire time you're there. So we saw a lot of spread. So this was kind of, we'd say, the perfect storm, in that we know that people with underlying conditions seem to be at risk for severe disease. So where do you have lots of people with underlying conditions? In the hospital. So you had the exposure, you had the right set of people, you had very close contacts. And so this allowed this infection to get established in multiple areas before it was identified. So the Republic of Korea took prompt action, very, very intense response to bring this under control. They quarantined over 17,000 people for this outbreak, but fortunately they were able to limit it to these, as I said, 186 cases. So finally, the last area I wanted to talk about was zoonotic influenza. And so, as you know, influenza viruses, we think, originated in animals. We think they originated in birds, and influenza viruses that have moved on to horses and dogs and people and pigs have all come from birds originally. And so it's not, so we do expect that zoonotic influenza infections will occur and will move into other species sporadically. But currently, we have a few of these zoonotic influenza viruses that are of particular concern to us, particularly the avian influenza virus H5N1, which has really been circulating since 2003, and the avian virus H7N9. And this was first identified in China in 2013. In the past, most avian influenza viruses that infected people were considered highly pathogenic in chickens, which meant that all the chickens you'd see them sick and the next day they'd all be dead. And so that made it easy to identify and control from the veterinary standpoint. So you could, when you have a bunch of dead chickens, there's a problem, you go in, you do a control measure, you keep, and so you can keep people from getting sick by controlling it in birds. With this new virus that's circulating in China, it's what we call a low pathogenic virus. It doesn't make chickens very sick. And so it's much harder to find out where those sick chickens are and do something about them. The reason this is important is because really the major risk factor for getting one of these zoonotic influenza viruses is being in contact with a sick or dead chicken. And so it's much harder with the low path viruses to do those measures on the veterinary side to prevent that exposure to people. So why this is, and it's important because these two viruses actually that have been circulating have around a 40 or 50% fatality rate. So even though these are sporadic infections, they are highly, they make people either severely ill or they kill them. And so it's of concern because we know with influenza that if we have an influenza virus, that these viruses now, mainly people get them from exposure to animals. Once a person is infected, we do not have much secondary human-to-human transmission. We've had a few clusters, but we've not really had it move more than maybe 3 levels from the initial. So we might have it move from one person to one person to one person, but really that's been the extent. But if we take this virus that, and it mutates, which influenza is very good at doing, if it can drift or shift enough to become more highly adapted to people so it spreads easily among people and none of us have any immunity to it, then that would be a pandemic influenza that we would, like the 1918 virus. So the pandemic influenza that could cause severe disease and severe fatality around the world. So that's why we get worried and we really want to limit this disease in people, don't allow it to get in people and adapt, and to control it. And that's the concern with these zoonotic infections. And so we say, okay, so why do we worry? If we look at just this year, the number of outbreaks that have been reported in animals to the OIE, the World Animal Health Authority, the only thing that is required to be reported are high-path viruses, which we know can infect people. These are the outbreaks that have been reported just this year. This has been a very bad year for birds, particularly in North America. For the first time, they've had a veterinary crisis has been declared because they've had such significant amount of high-path H5 avian influenza infections in the United States, affecting over 2/3 of the country. And we have outbreaks across the world. We've had last year, an outbreak ongoing in Egypt of H5N1, where we saw more cases and more human cases. And they thought that under investigation revealed that they think they're seeing more human cases there, not because of change in the virus, but because of change in behavior. With the instability that came with the Arab Spring and the changes in the political situation in Egypt, there's been some economic hardship, and more people are raising backyard birds, backyard chickens for their own consumption and sale, and they're doing this under poor biosecurity levels. So you're seeing more birds being infected and more people getting infected. So fortunately, we don't think it's a change in the virus, it's a change in the people. If we look at the distribution of cases of H7N9, it's a little different than H5N1. H5N1, we've got like 16 countries that have been infected, but with H7N9, it's really limited almost exclusively to just China. There have been a few cases that have been exported to Singapore, Hong Kong, Canada, but those never led on to any further disease. So, as I said, the main two avian flu viruses we're worried about are H7N9 and H5N1. And these have resulted in, as I said, mainly infections sporadically, but we're still seeing significant numbers, particularly H7N9, which has only been around for 2 years. We have over 600 cases and almost 300 deaths. Currently, since the last month or so, we've not had any new cases reported, but we do anticipate, because the infection is still in birds, that we will see this again. And now, if we look at swine influenza viruses, they've not been, we've not been seeing the numbers of cases of swine viruses or the severity that you see with the avian viruses, but we do know that swine pigs can be theorized to be mixing vessels, that they can get a human virus, an avian virus, and a pig virus at the same time and allow them to mutate. The example of this would be the pandemic H1N1 virus of 2009, we believe originated from reassortment within pigs between swine and avian viruses and got into people and caused the pandemic. In the United States, they've been having an outbreak of swine influenza viruses for the last few years, resulting in some sporadic infections. But the main risk of that is contact with pigs. So with these influenza viruses, as we said, we've had them for a while, but we have to keep a close eye on them to make sure that they don't mutate and become more infectious to people. So, we've talked about these viruses. What's the bottom line? Well, you know, this is a picture up here of just travel from the countries in West Africa to Europe that we looked at during Ebola. So these are flights and how people, just different flights that were occurring between those major capitals. So we know that even though we say a disease is occurring only in West Africa or only in Eastern China, it's important to remember in this day and age that that's only a plane flight away. In 24 hours, you can get about anywhere in the world. And so I think that we would say the risk to Europe, to these infections I've been talking about, the risk of an infection getting into Europe and spreading across Europe of these is low, because I think we have, for a number of reasons we'll talk about, but I think that we do anticipate that the risk that sporadic cases of these infections might show up remains possible. It's a risk. One thing that currently of concern is that the Hajj is wrapping up in Saudi Arabia, where we know that the majority of MERS cases have come from, and where most of the travelers who had MERS have come from. We know that healthcare settings are a risk, that we've had outbreaks in healthcare settings. We also know that this year, sadly, we have a significant number of pilgrims who had to seek healthcare as a result of the stampede. There was an event where people were injured from mass movement, a stampede, if you will. And so there's, I believe, something like 700 people had to be hospitalized following that, or 800. And so So this is something that, has to be on the radar of people coming back from the Hajj or from healthcare in Saudi Arabia, that we want to make sure that if any of them has respiratory disease, that we keep MERS coronavirus in our head as a possibility, because we want to get it under control if it shows up. So why do I say we think the risk of it spreading across Europe is low? It's because Europe has some of the best healthcare systems in the world. Republic of Korea has good healthcare, but it's also about being able to identify it and contain it. So we must remain, the important thing to remember is that we have to remain vigilant, because these viruses do have the potential to spread. We know that MERS can spread under the right situations. Look at what happened in Korea. And we also know that these influenza viruses have potential as a pandemic. So we have to be vigilant. So what should countries do? Countries need to strengthen their surveillance for acute respiratory disease as well as the other emerging infections, especially for travelers or migrants to affected areas, and carefully evaluate for unusual patterns. You must promptly investigate unusual events or suspect cases. You have to educate your healthcare workers and your communities about the symptoms and what to look for and what to do in the event they find something. And you must have strict adherence to infection prevention and control. And of course, all this goes with strengthening your core IHR capacities for reporting and responding to events. So if we come back to the question, is this a real event, or is this a hype? I mean, I think the issue is this is a balance. The risk is low. We don't panic, but these are things that we need to be aware of, concerned of, and educate our healthcare community. I do also agree with the last speaker that that this has to be taken in the context of that there are other infectious disease, known infectious disease, HIV. We're the only region in the world with an increasing rate of HIV. We have some countries with extremely low rates of vaccination, so measles, rubella, polio issues. All those things have to be taken in context. But so I want to leave you with a couple quotes that, this was a quote from an IHR committee meeting, say that the world is ill-prepared to respond to a severe pandemic or globally sustained and threatening public health emergency. And another one which says that the Republic of Korea is a wake-up call, that in a highly mobile world, we should always be prepared for unusual outbreaks. The important thing, I think, to note is that the first quote was from the committee reviewing the pandemic in 2009, and this last quote was from 2015. So the situation is the same. We're not prepared. I think that hopefully we're a little prepared more than we were in 2009, but we still have more work to do. And so with that, I want to thank you and have any questions.